Welcome to the Symposium on innovative approaches to increase performance of the health workforce. We're very happy that you made a decision to join this symposium, of course. And as a short introduction, I'd like to say that we are all involved in strengthening capacity of the health workforce. And we see it as a continuous process. It's not something that you do once and then it stops. And unfortunately, usually you need big budgets for training. And we all know that the funding is decreasing for training. And another issue is also that in TB at the moment, it's a very exciting time. There are lots of things happening, lots of things changing. So the content of the training needs to be updated all the time. So we think that it would be good to explore other cheaper, less time consuming, more effective capacity building options. So we are very happy that in this symposium we will offer you a variety of alternatives to traditional training. Just to name them, we will have a presentation on blended learning, on mobile learning, on the job training, photo voices, and new technologies for self-training. I would like beforehand already to thank the speakers who made time and effort to prepare presentations. And there is our last speaker. Excellent, Nacho, welcome. And so I would think that because usually we are short of time, so we will have like short presentations, 10 minutes, 12 minutes maybe, and then a few minutes for urgent questions and hopefully a discussion at the end. So I would like to start with introducing the first speaker. The first speaker is Dr. Nadine Bakker. She works at the Health E Foundation in the Netherlands, and she will present on blended learning on TB/HIV. Nadine?
That is not ours. Good afternoon. Thank you organizers, thank you audience for spending the last moments on Friday afternoon with us. And I'm very pleased to present on behalf of Health E Foundation. Let me introduce Health E Foundation first and then tell you a little bit on our model of learning, of education. So we are, as Lisbeth said, an organization based in Amsterdam, but our work is global. So we started in 2004. And basically we are a very small organization. We are only a couple of us in Amsterdam, but we have a very wide span with authors and local organizations supporting and facilitating the work that we do all over the world. Our mission, as it states here, is to provide education for doctors, nurses, counselors and other health professionals and information for communities on a large scale and in resource-poor settings. Now this mission really stems from 2003-2004. We've made some small adaptations there. We added the communities and I'll show you where those small changes come back to in our program. So over the years we have developed a wide curriculum of courses. And you see that we started with HIV. I highlighted the ones that are most in demand, as we say it. So over the years we've added other clinical courses, amongst others TB. And we also went more towards the preventive ways of healthy living. So those are concepts on hygiene, nutrition, and also maternal health in female and family education. So we try each year to develop something that is new, but we also continue to develop and update the existing courses on an annual basis. So if I show you, because we are here at the TB Union meeting, if I show you the TB education, you see that we invite the experts in the field to help us write the modules. They are very committed. They make sure that annually all the information is updated, which also means that trainees, our participants, always have access to updated information. And because part of what we do is so it's electronic learning, it also enables us to expand. So for instance, our HIV education course started with 12 modules, is now 25. And TB education is also growing as we speak. So the way that we train is according to the blended learning module. And that means that it's partly on-site and partly by e-learning. We really advocate this kind of learning because there was a trend at some point that everyone, the next generation would only do online learning, the MOOCs. And we know, of course, from MOOCs, especially for adult learning, it takes quite some effort to keep motivated and to finish successfully. So we feel that the combination of on-site learning and e-learning can be online and offline, is the ideal forum to stimulate people to successfully do their course, to also build teams, because we train different cadres of healthcare providers at one go. We train big groups, 50 to 100 people at go. So there's doctors, nurses interacting. It's good for team building, interaction and networking, and that all comes with the workshops. The e-learning, as said, can be done offline and online. We still train in very rural settings where we see that the old-fashioned USB sticks is a good way to train. This is kind of the model that we have. So we start with a kick-off workshop that is just one day. And it's really a way of getting people used to the system. In the early days, in 2005, 2006, we would go with computers themselves, and we had like 60, 70, 80% of computer illiterate people in the room. Nowadays, of course, a lot has changed. But the kick-off workshop is still very important to motivate people from the start. We have local guest speaker on the topic. And then we have usually a 3 to 4 months e-learning phase where we keep on boosting the participant group with SMSs, e-tutor, and even phone calls by the local team. Then there is a 2 days interactive follow-up workshop. You see in the pictures here that it's very interactive. So that is really the platform where we can exchange, where we can say, like, okay, you've learned a lot of theoretical concepts and knowledge, but how are you going to bring it into practice? What are your daily challenges and solutions? And you see there's a lot of cross-fertilization there. Then, of course, one moment we also have the certificate during the follow-up workshop. We always work in the countries where we implement our courses with the Ministry of Health or the Ministry of Education to make sure it's accredited and to make sure that people get their CME points, which is these days also a very important motivator. But then, and that is probably even one of the more important aspects, we don't stop there. So there is a CME part. By the time people finish their entrance course, you see that they are open to the whole curriculum, so all the courses that I showed you, and we really stimulate people to learn more. So we see that people who start with the HIV education course, they easily go to the TB education, for instance, or people who start with TB education, they move on with healthy living or other courses. So these days we have a participant pool of over 15,000, and you really see that people are very, how do you say that, very intrinsic in continue following and mentoring and networking. So the success rate, and that is truly the success rate of getting the certificate, so that is based on post-test results that are based in the e-learning course, is always like 85 to 100%. 85 we consider as a low success rate in our organization. Usually it's over 90. Success, of course, is also measured because we train the healthcare professionals, but of course you want to make sure that the impact is on the patient level. One measure of impact is, of course, quantity. Quantity, even though we, with our small team, managed to do blended learning for only a limited group, because of course the workshops are a laborious aspect of the work that we do. We train on average 1,500 healthcare workers per year. These are the figures of 2016. We've once calculated and also checked with our trainees that they see on average 1,500 patients over a year's period, and that is still on the lower side. We all know, of course, that healthcare providers in Africa, where we train mostly, they have an enormous work burden. So we see that actually, in quantity, the number of patients reached is enormous. So that is part of the impact. And you see that actually from the healthcare workers that are trained, the time they have to invest in this blended format really pays off in the effect that they can have on their patients. In quality, it's hard to measure, of course. We see that healthcare providers that trained with us, they are extremely motivated. They also continue to learn with us. We also see that people who've moved to other centers, organizations or hospitals, they usually are the ones calling us whether we can train other colleagues. So, but if it really resembles the quality of the work, it's hard to measure, as probably all of you can understand. But we do some long-term evaluations with our trainees as well, and they all look very positive. A little bit on how our development has been. So initially we were training on computers with USBs or online. We moved towards the tablets over time, and nowadays we are also having developed the apps, so it also works on smartphones, which is very helpful because they are always in the pocket, and as we know, adult learners, they have a problem in keeping everything there refreshed, so now they can also use it as a reference tool on a daily basis. The other development that we see, and that we see in TB but also in HIV, is that we see the shift in care these days. So initially all the care was doctor-centered, then you saw the decentralization towards nurses, counselors, and then in HIV we call it differentiated care, but also in TB you see the patient-centered community care. So you see that there is a shift of where knowledge needs to be. And that's also, where Healthy Foundation likes to step in. So we're not only training the healthcare providers, but also the communities. We see that, for instance, in Kenya, there's a big effort now in mobile money and mobile health wallets. So that is more like the app-based initiatives on making sure that healthcare can be paid, which is, of course, an important component. But we feel that there is also an additional value in making sure that these apps can also bring information. So except for training and education, we like to bring knowledge and information. So that is directly on the community level, either by SMS, apps on smartphones, or mobile phones. So this is really for focused groups like pregnant women or TB community workers. They can have skills and knowledge that they can bring directly to the communities. So this new program, we call it My Health at Hand. And we really feel, and you will also hear in the next presentations, that that's the way to go for the next few years. Sometimes the critical people, they start already asking us like, yeah, but not everyone has a smartphone. I think within 3 to 5 years they will be silent, because that's also what we saw when we introduced the e-learning in Africa. So hopefully this is the next generation that will get a lot of information on their app and basically also own their own patient information. Thank you for your attention.
Yes, thank you, Nadine, for a very interesting presentation. We have time for 1 or 2 questions. Are there any burning questions? The gentleman over there.
Thank you very much for your presentation. My name is Oscar Cordon from MSH. One thing when we are taking e-learning or distance learning programs is motivation and incentives, especially when we have busy schedules at the workplace. I have even experienced that myself, so I am interested to know, in terms of just encouraging people to continue opening the modules, following the homework, the assignments, what strategies you have included in your programs.
Okay, thank you. Well, one is, of course, that's exactly the reason why we do it blended, because during that kickoff workshop we already connect. So they do it for themselves mostly, but they know a face of the organizing people as well. And we always tell them during the kickoff that they are sort of a privileged group, that they can do this. So we really try to make them feel responsible, also to be motivated. Then during the e-learning, when we are not in day-to-day face-to-face contact with them, we send them emails, SMS, there is an e-tutor system, and we also have what we call a participant portal, so that they can also share amongst themselves. So if one from the participants is stuck because of whatever reason, they can link to their colleague participants rather than to us. Thank you.
There was one more question over there. Yeah.
Yeah, thank you so much, Nadine. And I think my first question has been taken by him. It was about engagement of the people, to make sure that they are still motivated to continue learning. But my second question is, I should think that you have got different modules, because we are talking about different cadres of healthcare workers. So I hope you have got different modules specifically designed for the different cadres that you are training.
Hij echoot een beetje. Okay, yeah. Sorry, there is some echo here. So different cadres. Well, the e-learning modules are similar, but for instance, we tell, I would be reluctant to say lower cadres, but let's say nurses, to skip the more difficult modules for the moment. But we always promote everyone to do the whole thing, and that also stimulates the team building, of course. And for the higher cadre professionals in the same group, it also shows that everyone is equal, you know, which is very important for that decentralized care. So we don't make a lot of distinction between what they learn, but there is a lot of group forming and team building during the training. Thank you.
Okay, thank you. Yeah, I think we have to stop here. At the end there is still space for other questions, but if not, we are running out of time.
Thank you for coming. It is estimated that by 2035, the world will experience a severe shortage of skilled doctors, nurses, and midwives. The only solution to this is community health care workers, community health workers. And how do we do it? We need to do it differently. Apart from the traditional training which you bring learners to a classroom setting, we are saying we have to innovate better ways of training them. I would like to welcome you to an exciting program. Leap Health is a powerful platform that is powered by training pedagogy, where the content is customized based on learners' needs and the partners' needs. What devices do we use? We use both basic and smartphones, whereby we explore the use of SMSs and interactive voice messages. You can reach any healthcare worker wherever they are and whenever you need them. Health content, you can deliver any health content, customized, where you can equip your workers with knowledge and skills to succeed in order to improve both learning and health outcomes. You can communicate anytime, anywhere, at the touch of a button. When you look at that photo, you can see a classroom setting of community health volunteers being trained. It is jumbled up. Mothers have come with their children because they have other duties to perform. When they're in a classroom setting, most probably they are thinking about their families at home. So it means with the traditional kind of training, learning stops when the learner leaves the classroom. Why are we doing this? Because community health workers need continuous training to be able to provide health education to the community, because they need to be supported by their supervisors while conducting their day-to-day activities. We are doing this because health volunteers need to stay connected with their peers. By staying connected with their peers, it means that whenever I experience a challenge within the community when I'm doing my duties, I can send a message to my fellow community health volunteer to help me sort out my problem. So we sort the issues affecting our communities together. Because CHVs needs to be provided with job aids and diagnostic trees. Whenever you go to a household, somebody tells you, I have a headache. Headache can be a cause of so many health problems. So you need a diagnostic tree that will help you and guide you to make a proper referral to a health facility. How we do it, it's a blended approach. We have basic modules derived from the National Curriculum of Training Community Health Volunteers. We also have other technical modules. For instance, now we are heading to NCDs. We have diabetes, hypertension, asthma, breast cancer, which we have it in SMART. SMART means that we are using the smartphones. We have images to describe and to take the learners through. We also have mental health as a topic. We have Ebola, trachoma, integrated community case management. We have TB, malaria, and HIV as some of the technical modules that are using the Leap Health platform. This is just to show you how the platform works. SMSs give you instructions. They give you directions on what you need to do. They guide you on where to get support and how to progress to the next level. So SMSs also support during the campaigns. We share out messages. Like recently we had cholera outbreak, we had dengue fever in Kenya, and we were able to contain the situation by the use of the Leap Health platform. So the impact wasn't very large because community health volunteers are spread across the community units. The interactive voice response, this is how it works.
Welcome to this session, dear learner. In this session, you will learn about how TB is spread and how it can be prevented. Dear learner, TB spreads very quickly among people who live in crowded places. Good housing will help to prevent the spread of TB. Encourage community members to play their role in preventing TB. They can prevent the spread of TB by opening windows to let fresh air into the households, uncovering their mouths and nose while coughing or sneezing. Should you notice the signs of TB illness during your regular household visits, encourage all the household members to visit the health facility for prompt medical evaluation and attention. As a community health volunteer, you should encourage any member of your community who has had exposure to TB to visit the health facility for checkup.
So basically that is an interactive voice response. A community health volunteer who has a basic smartphone, in Kenya we call them mulika mwizi, will be listening to the sound. If you have a smartphone, you'll be listening to you'll be seeing the images and reading the writings as they appear. Okay. So interactive voice responses also allows you to listen to mini lectures, role plays and case studies, which are real life scenarios within the community. This has proved to help the community health volunteers improve in the retention of the knowledge. It's easy for you to tell a story other than read notes, which you are going to forget. But when the notes are in form of a story, you are able to go and narrate the same story within the community. Let's listen to, sorry.
Welcome to this session, dear Lana. In this session, we will talk about common signs and symptoms of TB. Dear Lana, some common signs of TB are cough lasting weeks or more, night sweats, fever, chest pain, difficulty in breathing, and weight loss. Should you identify a person with these signs and symptoms, advise them to visit the health facility to be tested for TB. TB patients must be referred to the health facility for treatment. Treating patients with TB drugs is the best way to preventing the spread of TB. When treatment has started, the patient is no longer infectious. It takes a long time for the treatment to cure the disease. A patient takes TB drugs for approximately 6 months. You, as a community health volunteer, must check on the patient to be sure they take their medicine. If the patient does not continue taking their medicine, they will get sick again. The patient should try to rest and eat food for strength to fight the disease. Dear Lana, encourage the patient to visit the health facility as required for their health checkups.
You can, when you listen to that, you see the community health volunteer is being told exactly what her role or his role is within the community members. So if we want to eradicate, this is the way to go. Meet Stella. Stella comes from a remote village in Samburu County. This remote village is characterized by so many myths about TB and other diseases within the community. Stella's role is to inform people about disease. Stella's role is to refer people to health facilities and build the bridge between health facility systems and the communities. Stella is also charged with the responsibility of ensuring that people get counseling skills to eradicate issues of stigma and other challenges that may face the community. So Stella needs to be updated all times on what is happening. If there are any changes, they need to be told. When it comes to mobilization, Stella is very resourceful. So what Stella needs is a platform that is basic phone compatible with audio and SMSs. She needs decision trees to be able to support her in terms of getting job aids. And then she also undergoes randomized assessments to be able to know that Stella is actually well equipped with knowledge. When you provide a topic, you provide some tests and quizzes. So you provide some role plays which enable Stella to adopt the presentation in form of a role play and case study, which will make her retain that knowledge. Stella also has assignments to visit households and share what she has learned through the platform. Stella collaborates with other community health volunteers through group chat, whereby you are able to link with your fellow peers and you also link with your supervisors. Stella supervisor needs to get a report on how Stella is performing so that she is informed and is kept on track. When the supervisor, whom we call the community health extension worker, looks at their group chats and sees that they are chatting things that are out of context, he or she is able to bring them back to the topic of the week. A topic takes 4 days. It is available by default for 7 days. So Stella has no worry of performing other activities at home while doing the study. She has all the time to do her topic, understand, perform all the quizzes, and pass her exams so that she may be ranked as a top performer within the community unit, which is a motivating factor for her to continue with her study. That is Stella. After going through the topic, she has gone to the community to share the knowledge with the household members. You see, she does not need to carry so many books with her, unlike before, where she needed books, some places to refer to when she has forgotten. She only needs to go to her phone, use a function that we call the search function to get a reminder of the topic. She also has to access the help desk whenever she needs help, and she's in the community and she needs help. We have evidence to show that the training through LEAP improves the health outcome. We look at the learning outcomes and the health outcomes. We tested the 3 sites in the nomadic setting, rural setting, and urban settings. You look at the topic completion, which means that a CHV is able to go through the topic from the introduction, all the subtopics, the quizzes, and the practical exercises. And then we look at the improvement. How much has Stella been able to perform? If she performed 50% at the first attempt, she has a chance to search and redo the topic and improve up to 80%. That means she'll be able to understand the full content. When Stella understands, completes the topic, performs very well, the same is translated into improved health indicators. Because when you are doing improvement, women attending ANC visits, you want to improve on skill deliveries, you have to understand so that you go and share that knowledge, then you'll see the numbers coming out because you have shared the knowledge, you have done your referrals. And then look at the numbers at the increase in fully immunized children. In the interest of time, I will not go through, but I think you have seen the figures. Some of the success stories and testimonials are there. Christine says, during my household visit, I met a woman who was 7 months pregnant. She had swollen feet. Gladly, she listened to my advice of reducing salt intake, and I'm happy that she's now okay and also visits the ANC clinic. A CHV is happy when her knowledge has impact. She says that all these are happy because we know that we have done something and something has changed within the community. They appreciate that the discussions of Bakari and Juma, which are derived from the interactive voice responses, are nice ways of passing SMSs, passing knowledge, so the question and answering system are easy for them to understand. My wife has had high blood pressure. I have counseled her and she has adopted lifestyle changes such as reducing on salt and fat intake, taking lots of water and doing exercises. Her BP is now stable. As a CHV, you need to be a role model. So if you are learning a topic on hypertension, it has to start with your household. You have to change from your own household before. So those are some of the stories that we have. AMREF is keen on partnering with other stakeholders. These are the partners that we have worked with so far. We have seen improved indicators in each of these partners. I can't read all of them, sorry. We have very ambitious goals. Currently, we have trained 50,039 community health workers in Kenya today. 80,000 is our target by 2018 in Kenya. And across Africa, by 2020, we need to have trained 1 million community health volunteers. Finally, I would like to say, we believe that the power to transform the communities and to transform the world lies within the community health and the communities. So our vision is to Our vision is lasting health change in Africa, and our mission is to improve the health of the people in Kenya, Africa, and Sub-Saharan Africa. So let us focus on improving the capacity of community health volunteers to be able to eradicate some of this high disease burden across Africa, Latin America, and other countries. Thank you.
Thank you, Caroline, for this experience. Just a little time for one question. Any question from the audience? Yes?
Yeah, just a question about it's a question about the signal, because you showed community workers in the different areas. Do they have signal? They may have a phone always, but is there also signal in the rural villages, in the rural communities?
Okay, initially when we started, we had challenges where some of them were not able to access network, or what you call the signal, but with the introduction of the LEAP Smart is whereby we are able to provide images and they can learn offline. So it's no longer a challenge for us. We have an alternative to the basic learning whereby they can work offline once the data is already downloaded.
Okay, thank you. Caroline? Please
Just
hold your
before I
questions
sit-
for at the end of the session.
Before I sit, you can go to the App Store and download the LEAP demo for your trial. It's available on the App Store. Thank you very much.
Okay, thank you.
Okay, thank you very much. I'm Lamek, presenting on learning on the job to improve TB infection control practices in health facilities in Malawi. This is a presentation layout. I think in the interest of time, I will not go through this. This is where Malawi is, in the southern part of Africa, Sub-Saharan Africa. A bit of introduction about on-site training in Malawi. In a one-day program, district hospital infection prevention and control committees refreshed their knowledge about TB infection control, assess the risk areas at the facility, and develop or update the TB infection plan. This is a picture demonstrating the wind direction. It's a smoke tube. So this is a part of the health workers and the facilitators conducting a facility assessment at the district hospital. The milestone about TB infection in Malawi, so a bit of history. TB infection control, the NTP program in Malawi developed the TB infection control guidelines in 2009, and it took about 2 years before the actual implementation, because in 2011 the guidelines were distributed to high volume and medium volume TB registration sites, and this was done together with TB infection control off-site. The trainings were done between 2011 and 2014, and about 9 health facilities were trained with 406 participants, health workers trained in this off-site training. After like 3 years of implementation, we had an assessment on TB infection control practices in Malawi, and among the indicators that we wanted to see was like the triaging, which was done at like triaging of the health workers, of the patients coughing for 2 weeks or more, was being done in 28% of the facilities that were trained, and the facilities that had TB infection control plans were about 31%, and 41% of the assessed facilities said there was like nobody trained in TB infection control. This could be due to like staff turnover, because some of the health workers trained could go out, like some go to schools and they move to another facility. Now, with support from KNCV Challenge TB and the NTP, in 2016, we thought of revising the TB infection control guidelines, and these were this is a TB infection control guideline, and we also came up with the job aid. This is a manual full of SOPs, and the facilitators manual. And during this same period, we thought of changing the approach to training. As compared to the classroom training, we thought to change of the approach by doing the training approach on site. And by the end, these are just objectives of the training, that by the end of the training, which takes like 8 hours, it's a one-day training on site, and the team of members of the TB infection control committee at the facility are trained or refreshed their knowledge about TB. They conduct an assessment of the facility and develop the work plan. By the time we leave this facility, all the trained members of the committee make sure that they have a completed, well-developed TB infection control work plan. Some of you might ask, why on-job approach? The on-site training is more practical, because after the orientation, you move around the facilities to high-risk areas, conduct an assessment. So this is like learning while doing, and this might stick more. The TB infection control committee is easier to control because it's like a sizable group of people. Usually it's about 6 to 8 people. We only invite the core members of the committee. And as already said, funding for trainings are now decreasing. Hence, we need to go for a cheaper or less time-consuming trainings, because like now we are using Global Fund, but at some point we are like having no funds. But this will only require a team of 2 facilitators and at least 6 to 8 members of the TB infection control committee at the facility. When we get to a facility, we involve the core members of the TB infection prevention committee. This is like a general infection prevention committee, and usually we involve about 6 members, but at times they may go up to 8. Among the members, we make sure that the maintenance supervisor should be part of the team, because during our round of assessment, we find some places where we need some areas to be maintained. So he is also a very important member in this team. The training is followed up by supervision. So the team is mentored or supervised after 3 months following the first training, and then 6 months later after the first supervision. So, results. Maybe I have to mention that we started this approach in the 6 districts in Malawi, and these are district hospitals only. And among the first 6 districts, we saw that this on-site job approach led to realistic TB infection prevention and control plans with involvement of relevant departments owned by members of TB IPC committees and the hospital management. So this slide is just showing us the blue color is before the intervention and the red one is after the intervention. Here we're just comparing the 2 quarters, January to March before the intervention and April to June 2017 after the intervention. And here we are monitoring the 5 WHO standards, TB IC plan, triaging, designated TB infection control person, and ventilation and N95. So you can see that after the training, everything was maximized. Some challenges. We had the first few trainings, we faced some challenges in terms of time. We had very limited time because this is like a full day activity that is supposed to be done at the facility, and the members, the participants, most of the time they were like busy with other duties because we are doing this on site. So sometimes they might tell you, I'm busy in the lab, I'm busy in the ward, I'm doing ward round. So it was very difficult to control the time. And like for the last one, only monitoring of the 5 standards was also not part of the checklist that they use at the facility. So we also had some problems in monitoring this. Moving forward, in 2017, we have scaled up the approach to 107 facilities in the country using GF funds. And out of these, 287 health workers have been trained already from 83 facilities using the on-site approach. And by December this year, we need to train 24 more IPC committees. We also, on quarterly basis, monitor the WHO recommended IPC standards on quarterly basis to over 700 facilities. This is done through the joint TB HIV supervision that is done quarterly in the country. And the health workers diagnosed with TB will also be reported quarterly in the revised TB register that we have now developed in 2016. Previously, our TB register had no section where you could indicate the occupation of the patient. So it was difficult for us when you take the register to know how many patients, how many health workers had TB during this period. But from now we will be able to monitor the health workers that have got TB. In conclusion, this on-site training, mentoring and targeted supervision approach is expected to provide rapid increase in IPC compliance with the 5 WHO TB IPC standards. and as the national TB guidelines in Malawi sector. Finally, let me acknowledge the following for taking part in this initiative. Gracias.
Thank you, Lamek. Any questions at this point?
Thank you, Lamek. Healthcare workers are our greatest resource, and just want to applaud your effort for, doing our diligence to protect them. I'm curious to hear more about the diagnosis of healthcare workers with TB, just how that'll work, and whether there are any unexpected challenges with that process.
I'm sorry, there's a lot of...
I think the question is about how do you diagnose your healthcare workers?
If there's any screening process in place, or if it's going to, what that would look like, and if there are any unexpected challenges in diagnosing, treating.
This is another area where we have challenges, of course, not only in Malawi. From what I've seen in so many presentations here, screening the health workers is a challenge. However, in the three documents that I've shown you here, we have addressed that area. As a program, we have included we inform the facilities that they should have, screen the health workers at least once a year. During the training, we handle this area in detail, but as of now, we still don't have data to say we have done this. As you have just seen that our register has been revised just last year, so it has been in use mid 2016. So we still don't have enough information about how many health workers had TB. But the screening of the health workers is a very important area that we want to address, and we have highlighted in the manuals and even in the trainings that we do.
There's one more question. Is it short or, yeah?
Thank you for the wonderful presentation. I just wanted to ask if your training plan only focuses on the IPC committee, is there a training dissemination plan where the IPC can go and train basic people like in the hospital setting? If I were to think a general worker, a cleaner or a nurse also needs to be trained on infection control. So my question is there a training plan that would translate back to the worker general setting?
Yes, I think I've got your question. Our target is the TB IPC committee, but we don't state that the TB IPC committee should include this. After training of the TB IPC committee, it's their duty now to scale down the training to the health workers at the facility. So when we get to the facility, we only train the core people, and we also leave them with the materials, the documents, like the guidelines. We also leave them with the WHO TB infection control video. I don't know if you have seen it. And other relevant documents, like the posters for TB infection control, like cough etiquette and everything. So it is the duty of this committee now to train the rest. Thank you.
Okay. Thank you, Lamek, for your very interesting presentation. And there may be other questions at the end of the session.
My presentation will be focusing more on, not so much on the knowledge as well as on the attitude to increase to improve the performance of the healthcare workers. So first, the definition. Photophoresis is not a concept which is only used in health, nor only in TB, but is a process by which people are given the voice, then where they can identify, represent, and enhance their community through a specific photographic technique. Wang and Burris in 1997 defined it as this, and they also invented the Photophoresis methodology. It's also called participatory photography. You can see it also as a form of participation action research, because you get also a lot of information on the community and in our case, the patients. It has three main goals: to enable people to record and reflect their community strengths and their concerns, to promote a critical dialogue and a knowledge, and also to have it as an advocacy instrument to reach policymakers. So first now, the history of the Photophoresis I want to highlight. This is a Photophoresis in TB. And as I said already, it started in China, but that was not TB. Here in Mexico, at the border, Photophoresis was used for migrants. And here in Mexico, from 2008 to 2010, Photophoresis was introduced by Solución TB, which is an organization funded by USAID and worked together with the NTP to empower patients. We have here someone as a resource person also who was implementing it in the state of Jalisco. We implemented in 2010 in the Dominican Republic. When I say we, it's KNCV because that's where I work for. And during the project TB CAP, we introduced this voices and images of the TB in the Dominican Republic. So as you can see, this was the announcement. Invisibles means, of course, invisibles, and to get really a good impression what a TB patient is going through. So what is the purpose? The main purpose is to give TB its human face. It's the sensitization through images of key audiences to contribute to stigma reduction and discrimination for the community as a whole, as also for the healthcare workers, where we are talking about now. It's to empower also TB patients through the patients who are making the Photophoresis, as well as other patients who are recognizing their situation. And it's to create new spaces for communication outside the health facilities. There are 7 steps, and I've made it a bit brief, otherwise this could take a long talk. But there are like 7 steps. The first one is, of course, the preparation of this, where you need a coach who has experience in ontologic coaching, a TB clinician who knows what patients are going through, a documentarist to take note of all the information coming up during the session, 20 different types of patients, males, females, MDR TB, normal TB, sensitive TB, and other types of TB. And for TB healthcare workers who work with the patients to give them strength and confidence, and of course those having a good, already patient-centered attitude. 6 sessions are held with patients. In the first one, it's still where patients are new, they are not yet confident, they don't know each other, so it's an important moment to get to know each other, to feel comfortable, but that's not done directly going into their feelings, but also to equip them with the photo skills to make photographies and photo documentary. Then they get a home assignment to make, with the cameras we are giving to them, 10 pictures which provoke strong emotions. Not necessarily TB, but just strong emotions. What do you see in a picture? What can you provoke with a picture? Then they come back, and in the following sessions from 2 to 5, I don't want to go in all the details, they will share their emotions to each other in small groups first, of 3 people, and then they are showing also the pictures to a bigger group, showing, of course, also getting feedback on the quality of the picture, as well as discussing among each other what they felt when they took the picture. Bit by bit, after every session, they get the home assignment again to make another batch of 10 pictures. But bit by bit, they are feeling better because the ontological coaching gives them a positive feeling to have life goals, because that's the principle of ontological coaching, and to increase their self-esteem. And also through the feeling that they are photographers. It's not just, they are not just patients anymore, and they can express their feelings and what they felt when they went through the whole period of their sickness. At the end, in the last session, the selection is made in the group of 26 best pictures. So in 3 groups, they will choose more or less 10 pictures which are good in both aspects, in emotions as well as in technical quality. Next to those pictures, we will capture the quotes of the patients, what they felt when they took this picture. Well, I do something wrong? Okay. So these are a couple of pictures where you can see what they're doing. This is the first session. You see only a picture which is just giving a strong emotion. And here they are working in groups to tell each other what each picture was about. So they take the pictures, and the group, the facilitators are printing them before the session starts. And here you see the patients talking about their pictures. Okay, so I just want to show now in silence the pictures as a product of what was given with the quotes. So how does that link to the topic? How can healthcare workers, village workers, as well as also facility workers use these materials? Well, one of the ways is to use the material as such. These are just a couple of pictures because there were 26. But they can use it to provoke discussion in patient groups. So, and also in health education sessions with general patients, and to provoke the sentiments and to see what people feel and think about TB. If it's with patient groups, it goes, of course, very much more in depth, and it can really help each other to bring out their emotions. Then it is also to use to increase the self-esteem of the patients and to establish the patient support groups. The patients who worked in these activities were afterwards recruited as advocates. They were able to speak in big audiences to even the Ministry of Health and to other decision makers. They had a high self-esteem afterwards. The transcripts, which were done by the documentarists, were used for other materials. For example, we made also a video where you saw a positive image of a patient who, after being put on treatment, could continue with his work again. And that video is still used in the Dominican Republic. Last year they used it for the World TB Day still. Then you can use also of course, and that's the most used in the community. For the outreach, you can use it outside the health facilities, in municipalities, where you get more support from the authorities to get TB on the agenda and get collaboration with other sectors. So I think that's it. Thank you. Gracias.
Thank you, Nettie. Any questions from the audience about photo voices and how to use it? Okay.
Well, thank you very much, everyone, for remaining until the last one. It's not easy, it's a complicated day. So, well, given said that, let's start with this presentation. I have no conflict of interest. And let me show you a family picture. Do you have any kind of know-it-all relatives that knows everything and is always trying to be a little bit arrogant? Well, I have. I think everyone have this kind of relative. The point is that with Google in your hand now, you can contradict your family relative. And also people, this kind of people become much more prudent on their comments. The point is that new technologies is kind of even changing this kind of Christmas family parties because this kind of guy cannot talk anymore, or at least have to be much more wise. So just having this kind of Wikipedia and Google, it's really, really changing a lot. So another big example, this is currently my wife, it used to be my girlfriend, is my wife. We buy a massive house, it was a bar and we converted it into different houses. So she's working over there. And do you think we are nerds, library nerds, both are healthcare workers? Do you think that we have ever worked in construction? No, but we realized that a worker, a construction worker, is earning much more money than a Spanish doctor. So we were making numbers. And so what we do it ourselves. We have very motivated because we were with short money and there were wonderful YouTube tutorials for do whatever you want to do. So for electricity, for plumbing, for construction. So if you have the will and you have internet, and how many of you have these wonderful and horrible devices? Do you have anyone? Yes, almost everyone. So, of course, you can, if you are motivated, you can learn a lot about plumbing, electricity, or even demolish. So, the point is that internet is making knowledge much more democratic. You don't need to belong to any institution. You don't need a mentor. You just need the will to learn and internet access, right? Again, well, this is my hand. Yeah, I used to have one of these kind of ping pong tables, and I was asking help to one of my best friends. Probably I shouldn't, never did that. So we were moving this table, and the table opened with my hands inside. So I almost lose these 5 fingers, right? So the point is, how can I continue working? Because I was trying to do like this with the computer, but it was not feasible. But what I found is a Google application with microphone. The point is that, as you realize, I have a very strong Spanish accent, so I try to do my best BBC English, my dear. But I could continue working and writing my reports and doing my research. So I was extraordinarily motivated, and I could do it, even if I was handicapped for 2 months. So what I would like to tell is that there is major reasons for learning, especially if you are motivated, you can do it. But you can do it if you are forced, like for my injury, because I was needing, for example, for refurbish my house, because I didn't have much money, and also because I like it, because I love contradict people, right? And I love contradict these know-it-all people. So the point is that we find all of these key population among the studies, physicians, decision makers, and academia. So there is plenty that could be translated into the knowledge of TB and many other conditions. The point is that usually the most motivated healthcare worker, being a physician and nurse, is usually not coming to our face-to-face training. And this is precisely the people that we need to target. We need to target because if they are motivated and they want to make a change in their project or in their activities, they can do it just with a touch in the screen of their laptop or in their mobile phones or whatever it is. So my question is, are countries prepared for a quality care of MDR or XDR management? What do you think? Countries are prepared? Probably the answer is no. Why? Because there are too many cases, and just the figures talk. 50% of the MDR TB patients were successfully treated, meaning that 50% were not. So probably there are many, many reasons for this kind of horrible results, but there is a lack of expertise and training. And so far, as long as the medications for TB management, especially MDR and XDR, are long and toxic, treatment is going to be challenging. And sometimes what you find in the countries is that they are launched some kind of medications, they give you the guidelines, and then you have the patient. And fight. It's not going to work. Again, this kind of plastic bag model where you have prescriptions and you have doctors with a small training or not even with training doesn't really work. So